Hello, everyone. My name is Stacy Rothwell, and I'm a Field Services Program Manager here at the Oregon Office of Rural Health. And I would like to welcome you to the 37th Annual Oregon Rural Health Conference. I will be the moderator for this session. First, I'd like to just take a moment to thank our great sponsors. Because of their support during these challenging times, they've made it possible for us to offer this conference to you at no cost, and we're very grateful to them for that. Please join me in thanking our gold sponsors, the Oregon Rural Health Association and All Care Health, our silver sponsors, Eastern Oregon Coordinated Care Organization, the Oregon Association of Hospitals and Health Systems, and the River House on the Deschutes. Our bronze sponsor is RQI Partners, and our copper sponsors are Westcom, the American College of Education, and Inquisic. You should have received an email with a link to our conference app, and you can use the app to visit our partners' virtual booths. You can enter to win prizes, you can network with others, and we invite you to upload pictures of your community and your hometown. Next slide. Don't forget to complete your conference evaluation about this session. This will get you your continuing education credits, and even if you're not seeking continuing education credits, we still ask that you complete the evaluation, and it also puts you in a drawing for a $100 gift card. Keep in mind, we do read all of the evaluations and we value your input. Next slide. This session, Innovation at an Oregon Critical Access Hospital, will be presented by our friends at Samaritan North Lincoln Hospital. Please welcome Dr. Stephen Andescavage, Dr. Lesley Ogden, CEO, Virginia Riffle, COO, and Chris Lemar, Director of Facilities with Samaritan North Lincoln Hospital. Without further ado, I'll hand the presentation over to you, Dr. Ogden.
Thank you, Stacy. Today, we'll be discussing the innovation associated with building a new replacement critical access hospital in Lincoln City, Oregon. Next slide, please. We first started analysis for a replacement hospital in Lincoln City in 2008 as the old facility turned 40 years old and remained one of the only wood-built hospitals in the United States. At that time, the North Lincoln Health District owned the land and facilities, with Samaritan Health Services contracted for operations since 2001. After analysis, the health district was not confident that a multi-million-dollar bond referendum would be approved by voters. And by the mid-2010s, both the health district and Samaritan settled on a different direction, an asset exchange that would allow Samaritan to take over ownership of the hospital campus and in exchange bear the responsibility of building a new hospital. Subsequently, Samaritan hired a business analysis company, determined a budget based on the ability to pay the mortgage, interviewed potential architectural and construction partners, and visited recently built hospitals around Oregon and Washington. Once our partners were picked, architectural firm HGA out of their San Jose, California office, and construction firm Skanska USA out of their Portland office, we were able to determine whether to remodel the old hospital or build new. And the overwhelming recommendation was to build new. Next slide, please. We adopted an extremely ambitious vision statement and guiding principles and knew that operational transformation was needed in most of our service lines in order to accomplish the depth and breadth of the changes we proposed. Our design partner led us to form experience teams made up of frontline workers and community stakeholders, and they described the desired experiences our organization wanted to deliver to our patients, families, and staff. The experience teams then morphed into clinical program and process task forces that developed ideal workflows for key system core processes and clinical programs. The task forces then became service line design teams and identified space needs and ultimately designed the facility. We planned community engagement along the way and incorporated lean process improvement and identified transformation needed in our processes to accommodate the changes planned for our facility. Next slide, please. This slide outlines many of the inputs that drove the facility outcomes. The time and effort spent going through these steps allowed us to have much frontline worker and stakeholder input and built a culture where everyone was involved in the final outcome. For example, we aligned process goals and criteria with the voice of the customer. We went to see the current state in going on Gemba walks to identify current workarounds and process obstacles that needed improvement. And we developed current state process baselines of patient and staff workflow per department with value stream mapping. All of these steps informed the end result of an ideal and quality-focused facility with transformed processes and space relationships. Next slide, please. Of course, several major themes emerged in our planning. The first, concierge care, or the idea of bringing services to the patient instead of the patient going to the services. The second major theme that emerged was the ideal use of space. This includes efficient use of space, elimination of monument spaces, or those spaces that couldn't be used for more than one thing, and ideal adjacencies. And lastly, one of our major themes was flexibility and adaptability, where each space serves multiple purposes. Next slide, please. To show an example, this design image shows the front of our new hospital. In comparison to the old hospital, which had multiple entrances and lengthy hallways that were confusing, where people often got lost, despite it being a relatively small facility of about 74,000 square feet, we looked at a way to design the new hospital, identifying wayfinding and ease of navigation of utmost importance. So as a result, you can see we only have 2 public entrances to this hospital, at the main entrance on the right and the ER entrance that is 24/7 on the left. Next slide, please. In this design image, you can see the inside of the hospital at the main entrance. When you enter through this door, there are only 2 options for navigation: straight ahead through the cafeteria and by the information desk to the surgical unit, pharmacy, and inpatient units, or to the left to the outpatient and emergency services. Also, navigational prompts are built into the architecture, and you can see this at the main entrance and along public hallways. Next slide, please. In this design image and floor plan, I'll orient you to the hospital and the simplified navigation. At the south end of the building, you can see a loading dock with an employee entrance on the west side. This is an offstage entrance, meaning it leads to hallways and areas that patients and visitors do not usually see or traverse. This hallway connects to a north-south employee hallway, and that allows movements of supplies and bedded patients from all over the hospital unseen to the public. On the east side of the hospital are all the inpatient and observation rooms, as well as our labor and delivery unit, and most rooms have beautiful views of Devil's Lake. The main entry that we looked at earlier leads to a public hallway, bathrooms, our cafe, and the hallway ends at the inpatient wing. Alternately, turning left from the main entry leads to flexible rooms accommodating all outpatient services and to our emergency department with its own 24/7 entry on the north side of the building and adjacent to the helipad. I'll now turn it over to Dr. Steve Andescavage, our Emergency Department Medical Director, for a more specific description of the innovations within.
Okay, thank you, Dr. Ogden. Again, my name is Steve Andescavage. I'm the Medical Director, and I was involved in designing the Emergency Department. And I just want to say, if you're a provider in the audience and your department is undergoing a renovation or a rebuild, I would highly recommend you get involved. Your input is critical to get what you need. And I found the experience to be fun and, again, critical. We're going to go ahead and do a virtual tour here, or continue the virtual tour. And we're zooming in here on our emergency department and adjacent rooms. And what we've developed here is an emergency department that's flexible and scalable to needs of the emergency department. And we did this while maintaining our on-stage, off-stage workflow and continuing to preserve concierge service. And we did this also through universal treatment rooms. And we'll go ahead and define these through pictures in the next few slides. So let's start with the dedicated emergency department rooms. That is the group of orange boxes that, right there. We have 7 universal treatment rooms, meaning that they are large enough to accommodate any type of patient, whether you're going to be running a code, a trauma code, a nosebleed, an abdominal pain. I wanted rooms that could handle anything. So to get there, you need a room that is about 140 square feet or larger. And that's needed to bring in your portable ultrasound and your digital portable x-ray equipment. So again, concierge service, we're bringing everything we can to the patient in these dedicated emergency department rooms. So again, we have 7 emergency department rooms, we have a triage room. And then if you look at the green boxes, there's 4 boxes going down. This is what we call our flex space. So again, these are rooms that are able to handle any emergency. So that means they have medical gases, wall suction. If needed, we can run a code in one of these rooms. They're a little bit smaller, so we try to keep our lesser acuity patients out of these in these rooms. But if need be, we could get very busy seeing critical patients in these rooms. And we'll get to some pictures here in a little bit. And there at the bottom, you'll see a yellow row of boxes, and this is our diagnostic imaging rooms. And we've designed this so up to 3 of these rooms we can absorb as emergency department rooms. So again, they've got gases, they've got space for whatever we need to do. These rooms are specifically a DEXA scanner and 2 outpatient ultrasound rooms. Okay, let's go next slide, please. So on the left is the same schematic. So during business hours, Monday through Friday, we're running our emergency department in those top orange boxes. And what's happening in the green boxes are things like outpatient EKG, outpatient lab draws. If you're checking in to get an ultrasound or CT as an outpatient, those are what those rooms are used for. And then as the outpatient world closes down about 5 o'clock, we start to see our emergency department volumes rise. And now these flex rooms become emergency department rooms. And this is working out nicely. And in addition, we're able to use these rooms on the weekend as well, where our volumes tend to be higher. And then looking at the far right schematic, if we get into a situation where there's a mass casualty incident or just unusual high numbers of patients, we can go ahead and use those radiology rooms for emergency department use. Next slide, please. So I got a lot of information from this textbook. I have no financial disclosures. I became aware of this textbook by attending conferences, but this is a specific book on emergency department development and renovations, written by an architect. And the front half of the book talks about all kinds of concepts, using data to drive your decisions. So, how many rooms should your emergency department have based on your volume? How big your room should be? How many bathrooms do you need? I mean, just a wealth of information that was very valuable for me. And then the second half of the book are real world examples going over remodels or rebuilds or new builds of emergency departments, ranging from large tertiary centers to community hospitals down to rural and critical access hospitals. So really just showing you the floor plans and the processes, lessons learned. I mean, just a wealth of information here. Next slide, please. Okay, so this is a picture of one of the flex rooms. As you can see on the back wall there are inputs for gases, electricity, wall suction. Typically, we have a chair in there that can lie flat. We do a lot of lab draws out of these rooms, so we chose this chair, both lab personnel and the emergency department. It was a good compromise. But it's pretty big. It's bigger than our old emergency department rooms, but it demonstrates the flexibility that we've incorporated. Next slide, please. So this is stepping back a little bit. This is looking west. You can see 3 of the 4 doors to our access to our flex room. In the foreground, you're seeing our offstage workspace. And this is where our emergency doctors are, our PAs, our nurses, our techs, our registration personnel, our lab personnel. We all work in this. This has become our office. And there should never be any patients in this room. The only time a patient needs to be in this is when they're being escorted to the restroom or escorted to the CT scanner. We are really trying to bring every service that we can to the bedside, so we're not moving patients around. Next slide, please. Okay, so this is pictures of our old hospital. On the left, you're seeing what's described as the grand ballroom style of emergency department. This is a very commonly used design in emergency departments. So you're looking at 3 rooms that are divided by curtains. And I would argue that this may be good for providers, but it's not really good for patient experience. There's really limited privacy, sounds, smells, all get transmitted. So when we were given the options of developing an emergency department from scratch, I wanted closed rooms to enhance the patient experience. And on the picture on the right, you're seeing a workstation, and there's some problems here. So you're looking at desks that are fixed to the ground and cabinets, very hard to clean. Again, this is a workstation that is not off stage. So nurses' conversations are being heard by every patient family member in the emergency department. So again, doesn't create a great patient experience. Next slide. So this is looking east in our emergency department. So the rooms to the emergency department are going to be on the left slide, and then or on the left side of that slide. On the right side, you're seeing our workstation, and none of this stuff is fixed to the ground. So we're able to unlock these desks and move them to clean them. We can rearrange things if we need to. Again, there was a lot of thought in having this being very flexible. And again, there's no patients in this area. So this becomes our workstation. Next slide, please. So this is a comparison of one of our private rooms in the old emergency department and the universal treatment room on the right in our new hospital. As you can see, this room is narrow. There's basically no room for family members. Things are fixed in the room. You can't move things around. The bed is up against the wall, creating problems if you need to access that side of the patient. There's no gases in here. This room is really limiting to patient care as a provider. When you contrast that to the slide on the right, The bed is centered more in the room, so I can walk around to each side of the bed to access the patient. There are chairs there for family members you can see. It's just big enough to get our portable ultrasound and portable x-rays. So again, the concierge service is a very important concept here. Next slide, please. I think I'm done. Yes, I'm going to turn it over to Virginia Riffle for her portion of the presentation.
Both Dr. Ogden and Dr. Andescavage both touched on this, which is concierge services. And this is where we asked ourselves the really big question of how can we improve on the patient experience and bring services to the patient. In our old hospital, we had outpatient registration at one end of the hospital, and then lab, diagnostic imaging, cardiopulmonary surgery, and nurse educators all spread out through winding and confusing halls. So after much brainstorming with HGA, we designed what we call the flex rooms. So now the patients enter through the main hospital entrance, and they check in at a front desk, which is right inside that entrance, and they're assigned to rooms 1 through 4. The patients enter the flex room from the west side, and a registration staff member enters the from the work area on the east side. Registration then takes place in a HIPAA-compliant private room. Next, the registration staff member exits, and a phlebotomist enters to draw blood. Staff signal to each other for the next service by using a color-coded touch screen at the door, if needed, vocera. Depending on what they're here for, a respiratory therapist may be next to do an EKG, or the nurse educator may be next to provide instructions or supplies for an upcoming procedure. The point is, all these things are taking place in the same room. No longer is the patient wandering halls looking for services. If the patient also needs diagnostic imaging, they may be escorted directly to the DI department, or they may be asked to step out into the nearby waiting room. These rooms were designed to do all these services, just as we talked about, and also very importantly, as Dr. Andescavage described, to be available for ED expansion. There's no stretchers in these rooms, so they'll mostly be used for ESI level 4 and 5 ED patients. All in all, we're really excited about the new innovative way of providing services to our patients. Next slide. This slide shows our waiting area outside the flex rooms and the DI department. Notice the pretty rock fireplace at the end that separates the outpatient waiting area from the ED waiting area. Next slide. So referring back again to our old hospital, remember we had lab, DI, cardiopulmonary, and registration staff all at various locations throughout the building. With our new hospital design, where these services are co-located in this area of the building, this gave us the opportunity to rethink staffing. Because we're a small critical access hospital, each of these departments only had 1 or 2 registration or scheduling staff. Having an entity of only 1 or 2 can be very difficult if for some reason a staff member is out with an illness or on vacation. So we decided to do a restructure, and instead of the title DI Registrar or Cardiopulmonary Scheduler, they all have a common title of Patient Access Specialist. They all have one manager who oversees their competence and training. So no longer do they just work one department, answering phones for just that department, only doing the work queue for that department, but they can be cross-trained to work multiple departments. They can cover for each other for meal breaks and paid time off. We're also excited because it gives the staff member more opportunities to cross-train and to learn new skills. Next slide. So next I'll talk about our inpatient flexibility. The purple area on this slide is our inpatient beds. We have 4 ICU beds, 6 med-surg, and 4 observation beds in blue. The orange area at the bottom of the slide is our 2 labor and delivery rooms. Because our deliveries typically range between 7 to 12 per month, we decided to have flexibility in the inpatient area also. So we designed 2 inpatient flex rooms that can be used for either med-surg or for postpartum patients. You'll notice there are 3 red lines on the slide, a little hard to see, but these represent locking doors for the family birth center. We can expand from 2 rooms to 4, depending on which doors are used to secure the unit. Another innovative approach that's unique to our hospital is our OR. While our OB and our nursery providers hoped we could build a dedicated C-section suite, our low volumes of deliveries really didn't justify that major expense, so we problem solved with the next best thing. In our old hospital, our family birth center and our OR were on opposite sides of the building, so in emergencies, patients were rushed through public hallways to the OR. Here, we purposely located our OR adjacent to our labor and delivery rooms and planned an emergency entrance to the OR. Now, with the touch of a secure emergency button, the doors from labor and delivery open, as does the emergency doors to OR2. In a matter of seconds, a mother can be rushed into the OR. We have security measures in place that prevent the doors from being opened if the OR is in use. In that case, the adjacencies of the departments, it isn't much farther for staff to travel to get to the other OR. So all in all, much better than the old hospital. Next slide. Next. This is a picture of our inpatient hallway with the closed family birth center doors at the end there. Also notice the deployed nursing stations at the patient rooms. Nurses and aides can chart and monitor patients through windows at each of these locations. Next slide. This is a picture of one of our inpatient rooms. Each room has a patient lift, electronic whiteboards, and the ability to monitor patients with Avasys cameras. The rooms have an area for the visitors to relax on either a pull-out chair or a sofa, and many of the rooms have a wonderful view of Devil's Lake. Next slide. Another area that we wanted to give careful consideration to in our design was our public spaces. We didn't want our gift shop to take up a large footprint, so we designed a kiosk that can expand when open and be secured when closed. And in a non-COVID times, our auxiliary members operate the gift shop kiosk and provide assistance at the neighboring information desk. Next slide. Here you'll see we designed our cafeteria seating area right inside the main entrance. This way, the staff and the patients and the visitors can enjoy the amazing beauty of this area, both inside and out, with all the glass we have in this area. And we also purposely placed a conference room next to the cafeteria seating area, so the sliding doors to the conference room can be opened for additional seating during meal times. Next slide. Quickly, I'll show you the campus map. You'll see the new hospital with the parking area. The parking areas was where the old hospital was located. We have clinics, physical rehab, an early learning center, conference space, administration, and ancillary services in the other buildings on the campus. Next slide. We moved into our new hospital in February of this year, just in time for a pandemic to hit. COVID has definitely affected how we use our hospital. During COVID, we're only using one entrance for patients, staff, and visitors, that entrance being the emergency entrance. All entrance screening takes place here with 2 screeners. Our COVID surge plan includes expansion into the surgery pre and post and PACU rooms if needed for either emergency or inpatient care. We also have plans to place a triage or treatment tent outside the ER entrance if needed. Next slide. So future growth. Again, we kept coming back to lessons learned from our old hospital, where it didn't seem to us like the designers 50 years ago really planned for future change. And we didn't want people asking 20 years from now, what were they thinking? So we identified areas that we thought were most likely to have potential expansion needs in the future, and then we purposely designed these areas on the perimeter of the building so as not to be boxed in. The red dotted lines show potential expansion sites. As you can see, our ED can expand to the north as well as our inpatient unit, and our labor and delivery down at the bottom can expand to the south. And then we also aligned our two ORs in the north to south. So if we need to add a third OR, we can easily add that to the south of the building. And that's it for me. So now I'm going to turn it over to Chris Lemar to review the technical and regulatory considerations we encountered with our design.
Thank you, Virginia. I'd like to spend a few minutes building on the concepts of adaptability and flexibility and how that intersects with the authority having jurisdiction, which in this case was the Facilities Planning and Safety Division of the Oregon Health Authority. Samaritan North Lincoln Hospital was designed under the purview of the Oregon Administrative Rules prior to the adoption of the FGI guidelines in January of 2020. The adoption of the FGI guidelines has allowed for further flexibility in design, and in some cases beyond what was previously allowed with the Oregon Administrative Rules. It became apparent early in the design phase that some of the concepts being proposed to maximize efficiency and adaptability would require a collaborative relationship with facilities planning and safety, as these concepts did not necessarily conform with specific requirements as prescribed in the OARs. This collaborative relationship with FPS allowed the design team and hospital leadership to find common ground with the new concepts and language compliance. That allowed the facility to meet the intent of the Oregon Administrative Rules. In some cases, waivers were requested to deviate from the Oregon rules, using FGI guidelines as a reference to the deviation, as it was known at the time that facilities planning and safety was working to adopt the FGI guidelines in the near future. The intent of these waivers was to relax some of the requirements for specific spaces that would create a redundancy and allow for better use and sharing of support space. The guiding principles for this design included multiple use spaces and adjacencies to support staffing, patient flow, and efficiency. In order to satisfy these principles, some creative space planning and multi-use room schemes were needed. In many cases, the proposed multi-use room schemes and shared spaces were not clearly defined in the OARs, and this created a situation where facilities planning had to find a method to evaluate whether the proposed design would meet the base requirements and the intent of the Oregon Administrative Rules. So let's take a look at the outpatient flex rooms as the first example. These rooms are used primarily for outpatient services such as lab draws, EKG studies, pre-surgical counseling, and other similar functions during the daytime hours. There was also a need identified to have scalability in the emergency department to accommodate a large patient load during peak hours. Positioning the outpatient flex rooms with an opening to the emergency department accomplished this task. However, there was no rule section for this configuration within the OARs to provide guidance on how these rooms should be designed and reviewed. Hospital leadership collaborated with FPS to select the proper code sections to apply to these rooms that best fit both outpatient and emergency department functionality in a high emergency department census scenario. The outcome of this collaboration was the decision to apply multiple sections of the OARs to these rooms in order to make them comply with multiple uses and to combine support functions with the ED to meet the requirements. The following were the sections of the OARs we ended up using, which is a combination of the outpatient facility section and the urgent care section for the room design for themselves. And the ED support spaces came out of the ED support requirement spaces from the ED section. Another example of the flexibility in design and the collaboration between FPS and the hospital is the observation rooms. These rooms are physically located in the inpatient corridor directly adjacent to the inpatient intensive care rooms. These rooms were not reviewed under the inpatient room section of the OARs. The decision to place the rooms in the inpatient corridor was made for operational and staffing reasons to work in conjunction with our staffing model. The observation rooms were reviewed under the emergency department rules as they most closely fit the emergency department function than they did the inpatient function. The support spaces for these rooms were combined with the inpatient function unit or inpatient unit in order to ensure space was used efficiently. This allowed for a smaller room space than a typical inpatient room, with a more relaxed requirement for restrooms and showers and no requirement for an exterior window. A final example of negotiation and flexibility with FPS is the direct entry to the operating suite for emergency sections. In a traditional hospital setting, you would most likely not find direct access from a corridor to one of the operating suites. This was a new approach and one that took some negotiation with FPS to accept and allow. Our obstetrical department does not have the volume to support an in-unit C-section suite, but fast and direct access is needed for safety reasons in emergent cases. This approach required many discussions with FPS to devise a scheme to protect the operating room environment if the access were used from the corridor. And this required some innovative solutions that are not defined in the OARs. For example, ventilation requirements for the operating suite need to be maintained at all times. To meet this requirement, a vestibule was needed between the corridor and the operating room to ensure that the environment remained in a positive state and protected from the external environment. In addition to the vestibule, the mechanical systems and room pressurization schemes would have to be robust enough to handle a door opening to a vestibule and ultimately to a corridor. In addition, FPS requested an interlock to protect the door from being operated if there was a surgery occurring in the operating room. This was accomplished by a switch controlled by the surgery staff to disable door operation during active cases. This negotiation in a whole took a little bit of time through the design process, but ultimately FPS worked with the hospital to find a solution that would meet the operation. As a key takeaway in all of this, I would like to encourage all who are designing new facilities or undertaking renovation to not feel as if they're locked into what is written in the FGI guidelines. You can use the guidelines as a basis for design, but also challenge yourself to think about new approaches that may break from traditional design to meet your needs. When you develop innovative ideas, it's important to work closely with the Facilities Planning and Safety Department to find creative ways to meet the intent of the FGI, but also meet your operational needs. In our experience, there was also always a solution and middle ground to be found with FPS, and they will indeed partner with you to help you accomplish your goals and meet your needs. Next slide. In the last few minutes, I wanted to talk about our approach to ensuring we designed a building that was not only efficient, but also cost-effective in terms of construction using current design technology. We chose to use a 100% building information model, which is short for, or the acronym is BIM, for the design and construction of the new facility from the outset. Next slide. Building information management simply means a model that's built virtually before a facility is built and is a digital representation of physical and functional characteristics of the facility. It's just as it sounds. The BIM is a shared knowledge resource for information about a facility, forming a reliable basis for decisions during its life cycle, defined as existing from earliest concept to demolition. The reasoning for a 100% BIM model from the outset was threefold. First, we wanted to make sure that we were procuring and installing materials in the most efficient and cost-effective manner in order to keep the cost of the project down. BIM aids in this endeavor by allowing all systems to be built virtually in a model and evaluated for best routing and travel pathways to keep material costs down. Another feature of this model is that it allows subcontractors to have dedicated planes in which to work that would deconflict the workspace and allow multiple trades to work at one time instead of having one trade predominantly working in one area. This efficiency in construction led to a financial savings related to the time of facility construction, and it also helped to accelerate the schedule, which resulted in financial savings and general conditions costs. Second, in order to ensure the facility is maintenance friendly in the future, BIM was used for clash detection and serviceability of components. A BIM model allows for clashes or interference of pipes, valves, and other components to be detected and called out in the model prior to installation. This is a cost savings benefit as early detection of these clashes translate into less rework being done in the field during construction. It also ensures that down the road, all critical components are accessible for servicing by maintenance staff and vendors. This provides an upfront cost savings, but lifecycle cost savings for vendors performing the work in the facility and aids in ensuring downtime is kept to a minimum when components fail, as they're easily identifiable on the BIM model to include exact locations with reference points in the facility. Finally, a 100% BIM model provides greater detail when it comes to future design and construction. The model allows architects and engineers to know exact locations of every component of the building down to the foundation, and this is especially useful when a renovation to the facility is planned. The ability to find utilities, structure, and other key components can streamline the design and make the construction less evasive. So I'd like to go through about 3 slides with you and kind of show you some snippets from our BIM model. So slide 1 you're looking at right now. This is an example of above ceiling coordination that took place in the model prior to the construction. The slide shows the final coordination after all clashes had been identified and removed prior to installation in the field. Another item of interest in this slide is the coordination of the trades and how the trades each had a dedicated plane or elevation, in other words, in which to work and install their components. Next slide. Slide 2 is a model of the entire building looking from the west with a focus on the foundation and pilings. This can be useful for future designs and for evaluation of facility performance after an earthquake event by structural engineers. Next slide, please. The final slide shows a top view of the facility to include clearances and circulation for trucks delivering supplies to the hospital. The modeling of circulation of the loading dock was crucial in developing a right-size space for this area, so there was no waste of space, which is a direct driver of construction costs. Well, I'd like to close with technology in the construction industry is advanced today, and it continues to advance with each passing day. BIM models provide crucial information about a facility that is used in everyday operations as well as in emergent situations. I recommend the use of a BIM model as a tool in projects for planning, construction, and maintenance. In our case, I can say this model has already been used several times since occupancy to locate certain components in the building for troubleshooting and has proven to be an exceptional tool when planning and performing routine and unscheduled maintenance on building systems. And with that, I would like to turn it back over to Dr. Ogden so she can take you through the remainder of the presentation.
Thank you, Chris. As you know, we encountered many challenges along the way with our efforts to redefine how healthcare is delivered in our hospital and to our community. So the first one we'd like to talk about is cultural silos. Many of our departments worked in isolated silos in our own hospital, but the new hospital incorporated new teams, new workspaces, and broke down many of those cultural silos. Staffs now share their work and break areas very differently, and it's made us a better team overall, but it was challenging to go through those changes. The second area is staff buy-in. It was very important that we included frontline workers and stakeholders from the very beginning. Although it didn't totally eliminate minor complaints, we were able to bring along our staff members on our journey and negotiate impending changes over years instead of days. And then lastly, change management. Ultimately, this was the biggest change management project we'd ever undertaken, and we wouldn't have been successful without partners like HGA and Skanska who understood and led us through the steps to achieve success. Next slide. After navigating those challenges, we were able to quantify well over $1 million savings in construction costs through value engineering, despite having to increase our initial budget of $35 million to $45 million because of rising labor and supply costs, as well as due to the density of our floor plan, which resulted in increased complexity of our project. In addition, we were able to identify lots of equipment and operational savings based on expert negotiation with suppliers, transformed building performance, and idealized staffing and redefined job roles. Finally, this building allowed flexibility for fluctuations in volumes, including surge plans and service line changes that we hope serve our community and hospital operations much better over the next 50 years. Next slide. Here's a picture of just some of our team members who worked tirelessly over multiple years to accomplish the following vision: to create a world-class, award-winning, community-centered rural hospital campus that will challenge conventional expectations, be patient and family-centric, flexible, scalable, and reflective of our local culture. We envision a state-of-the-art hospital campus that exemplifies excellence and is environmentally conscious, sustainable, timeless, and mission-driven. And we believe we did it. Thank you so much for joining us for our Innovation in Critical Access Hospitals.
Thank you all for sharing the great innovations and efficiencies you've created at Samaritan North Lincoln. I can attest that your facility is truly gorgeous, and I really commend you for your hard work and dedication in creating this for your community for years to come. We will now go to the question and answer session.
Hello, everyone. So we are now in the live Q&A session. Just a reminder for all of our participants that if you do have any questions, feel free to type in the Q&A box down on the lower right-hand side of your screen, and we will get to those. I do have a couple of questions that we've got so far. So I'll start with the first one. Have you seen a correlation among patient experience scores since the opening of your new facility? And on the same note, how about clinical staff and employee satisfaction scores?
I don't know who wants to take this one, but I'll get us started. Well, here was the tough part. Is right when we opened the hospital, we ran into COVID. And so we saw quite a bit in our patient experience referencing COVID restrictions. And so we knew it wasn't a commentary on our new hospital, but rather it was a commentary on the restrictions that we had to put in place. And everybody remembers that when we first started this response to the pandemic, we saw very strict visitor restrictions. We saw lots of limitations on who would care for a patient. We've since learned so much more about COVID, how to protect ourselves and how to protect both our staff members and our patients. And we've been able to relax quite a few of those restrictions so that we can enhance the patient experience. And yes, as of this last quarter, we have seen our patient experience numbers just jettison a complete and total, like off the charts sort of appearance. So Virginia, you want to take a stab at the second part of that question about employees and staff?
Yeah, and I'll just add on to the some of the things that we were working on in the old hospital, such as quietness at night, things like that, that we just struggled with. And yes, it's so nice to see improved scores there. So as far as the employees go, we haven't done a survey of them since moving into the hospital, an official survey of that sort. We're going to be submitting one here soon, so we hope to get some feedback. But just from the verbal feedback from working with the managers and working with the teams, this hospital leads to greater efficiencies for the staff. It leads to improved communications and workflows. So there is this greater sense of teamwork and we believe greater sense of job satisfaction. Hope that answered the question.
I think it did. And it seems like it would be a given that all of your patient experience scores and everything would go way up. And we all know that the data lags and it takes a little while to get it in. So I'm sure that you'll continue to see successes in both of those areas. My next question is, prior to facility planning, and did Samaritan North Lincoln implement process improvement techniques such as Lean or Six Sigma to assist you in process planning for your new facility? And if so, what processes did you incorporate?
I can start that and then everybody else can fill in. We very much have been on a process improvement journey. I guess some of the toughest part is to figure out, like we've gone through different lean trainings, and they were accomplished by different organizations, and some we found to be more effective than others. And so we continue that process. But yes, lean process improvement and Six Sigma was part of this process as well. So we were on the journey before, then we went through the journey as well as part of the construction planning process. And then, you know, we continue even this fall. We found some additional lean training for our managers that we wanted them to participate with more in depth. We want to arm them with ways to solve their own problems. And that's some of the toughest part in healthcare, right? Is you know you have a problem, but how do you fix it? And so lean process improvement is one of those tools we can put in their tool belt.
Yeah, Lesley, you showed a slide on that. So as Lesley said, we started our lean journey. There was certain employees and managers and quality directors who had received lean trainings, and we put it to use in our old hospital, and you know, spaghetti diagrams, organizing storage rooms, things like this. But with the hospital design, it was really put to use. HTA did bring a lean expert out to us and worked with us through a wide variety of lean processes, such as the Gemba walks and value mapping and all different kinds of, you know, future state, current state, all kinds of different processes that the teams went through, and it really helped set the goals for what we were trying to achieve with our hospital design. And as Lesley said, we're on the journey now. Pretty much every single one of our managers is attending a lean weekly training, and so it's in the works now, and they're all working on the project of their choice of what they would like to work on improvement. So yeah, we're on the lean journey.
Perfect, thank you. My next question, we could almost probably have another session on this particular question as a whole. But did your facility have to undergo a new cost survey by CMS? And if so, did you have any lessons learned that you could share to the participants for that?
Oh, yes, surveys, how lovely they are. Well, people may not know, but this is actually the second hospital that that I have been privy to be over at the time of construction. And we very much had a strategy for both of these new hospitals that we would keep the same address, keep the same footprint as much as possible, really try to minimize anything that would flag another survey. However, unfortunately, because this project at North Lincoln has no remodel components, even though we had the same address, because it was a brand new footprint and a brand new building that was separate, completely separate from the old one, it did trigger a license survey, a new licensure survey. And so this was through the OHA. It was not a critical access hospital survey. It was more intense, I would say. So we very much had to work through that process with the Oregon Health Authority and reassure them that we could deliver the same or better care in our new environment in a very short period of time. And it was very intense, but we came through with flying colors.
It was very intense. But shortly after that, we did have our accrediting body, which is DNV, come through and survey us. That went, both surveys went well. So we did have the 2 survey processes.
Yeah. So that was the licensure survey and then the facility survey. And the licensure survey was much more intense. The facility survey was sort of a one-day, we just need to make sure that you're doing life and safety, sorts of things. And Chris can certainly comment on that survey. But I thought it was very good, as far as on our side. What do you think, Chris? Oh, you're on mute.
Sorry about that. Yeah, the facility survey went well. It was more of a confirmation that we built what we said we were going to build, because the design and approval part through FPS is more done up front, meaning they do all their due diligence in the schematic design and construction documentation phase and give you approval at that point. So basically what they do is come out and make sure that you use the right techniques and build what you said you were going to build. But it went real well.
That's perfect. Yeah, that is a big other subject to discuss. Probably a lot of follow-up questions pertaining to that, potentially from other facilities who might be, looking at building on or building a new facility in their futures. One last question I had for Dr. Andescavage. You clearly were a champion that led the clinical side of it and design of the hospital. How did your colleagues work in that process with you? And were they accepting of it? Was it more of a team thing, or were you just more presenting ideas and getting feedback? How did you feel?
Great question. So my component was strictly to the emergency department and the diagnostic imaging, which we were paired together with. The most powerful thing that we did was we toured an ER that we wanted to copy with lead nursing, and they were able to go to the facility, interview other staff that work in that emergency department, and really get excited about the change that we were going to make, because it is a drastic change. So really empowering all levels and all personnel at your department. So it's not coming top down, and you really engage your coworkers and your employees. And it really was pretty easy, honestly.
Perfect. Okay, well, I am not seeing any additional questions coming in through the chat box. So I think that we are coming to the end of the session. I wanted to just thank you guys so much for sharing this journey with everyone, and thank the audience for listening in. We're going to be entering a lunch break right now. So we're going to start back up at 1 o'clock this afternoon to hear Dr. David Lehrfeld's presentation on EMS in rural and frontier Oregon. Thank you, everyone.